The "it's always the right time" deal.
Hey, want to go to Mickey D's for lunch?
Ooh, let's go now.
But it's not lunchtime yet.
If we're going to McDonald's, it's always the right time.
Yeah, it's hard to argue with that.
There's a deal for every lunch hour at McDonald's.
Now's the time to get 2 for $3.99. Mix and match a 4-piece McNuggets, a McDouble, a McChicken, or a hot and spicy McChicken. Price and participation may vary. Cannot be combined with any other offer. Single item at regular price.
Yeah, so we deliver the CDC's National Diabetes Prevention Program through telehealth and live group video conferencing on Zoom with registered dietitians.
Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello again. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar from Rehab Practice Solutions. And if you run an innovative healthcare organization, maybe you're a tech company, a SaaS company, maybe you're just an innovative service provider, and you are looking for a way to align your service offering with your target market, check out the Healthcare Positioning Alignment Workshop. It is something we are running from now until the end of the year. Basically, what we do is we help you identify your most valuable target market. We help you develop an effective value proposition for that stakeholder, basically by narrowing down the quote, value to whom, unquote. You have a clearer understanding and idea of how your tech, your device, or your service is positioned to solve the problems faced by those specific healthcare stakeholders that you're targeting. So you can learn more about that at positioning.rehabpracticesolutions.com. If you have questions, there's plenty of buttons and links there to book a call with me, or you can shoot an email to info@rehabpracticesolutions.com to learn more about that, how much it costs, all of that. It is all on the website there. You can go find that. Again, the link for that is positioning.rehabpracticesolutions.com. Alrighty. This week, we are going to continue our delve into some innovative healthcare service delivery options here. And what we're going to actually talk about is using telehealth for diabetes prevention, not diabetes management, diabetes prevention. So my guest, I'm just going to go ahead and talk about him a little bit, and then we'll dive into my thoughts and then the interview itself. So Lawrence Gerard he's the CEO, he's the founder of Fruit Street Health Clinic. And what they do is they deliver the CDC's diabetes prevention program via telehealth. So one of the things that Lawrence noticed in his schooling was that a lot of the people that present or that show up into emergency departments across the country are there because of or in reference to maybe ancillary symptoms or secondary symptoms stemming from chronic conditions like diabetes. And part of the problem in managing that or preventing that is that there's a lack of sometimes availability of the prevention programs. You know, like, are you going to get somebody that lives in rural Georgia, for example, to drive 2 hours into the metro area once a week or twice a week or whatever to do a diabetes prevention program, even if you know that diabetes prevention program is going to prevent, it's a prevention program that prevents, right? It's going to prevent in the long run all these negative side effects or outcomes that happen when a person develops diabetes. You know, maybe it's medication, increased medical usage, hopefully not, but sometimes, you know, kidney disease, a dialysis, and amputations and the like. if there was a way to deliver those services to cut off or prevent that chronic conditioning from happening in the first place, obviously the logic goes you can prevent all of those negative downstream effects. So Fruit Street delivers the CDC's diabetes prevention program via telehealth, which increases access. Now, he talks a little bit about the strategy that they've taken and how they're going directly to employers and the like, basically because some of this is not covered by insurance yet. Hopefully that is something that will change over time. But some of the statistics that he threw out were very eye-opening to me. And I mean, obviously we know that Americans in general here in the US are not the healthiest people in the world, right? A lot of us are overweight. A lot of us are at risk for diabetes and some of these chronic conditions. I think he says somewhere in there that like 1 in 3 people that are pre-diabetic end up getting diabetes, which is one of those like, man, if you could find a way to cut that in half, you'd save tons and tons of money. So anyways, it was an interesting conversation talking about using telehealth as a way to expand access to prevention programs that can hopefully save payers and patients and even providers a lot of time, energy, and money. So without further ado, here is Lawrence Gerard talking about delivering diabetes prevention programs via telehealth and group conferencing. Well, hey, Lawrence, welcome to the show. How are you?
Good. Thank you. How are you?
I'm doing all right. I'm looking forward to talking with you about Fruit Street and diabetes prevention and management through all that, remotely. But before we dive into, remote diabetes prevention, why don't you tell me a little bit about yourself, what brought you to what you're doing at Fruit Street, and we'll kind of dive in from there.
Yeah, well, I was planning to go to medical school when I was in college, and I had this experience where I was volunteering in an emergency room while taking a nutrition epidemiology course with a Harvard School public health professor. And I saw a very obese man come in and die from a heart attack that appeared to be related to his obesity. And I just realized at that point that a lot of the patients coming into the emergency room had preventable conditions related to their diet and lifestyle. So they had heart disease, stroke, diabetes, obesity, amputations, dialysis, and I just realized that we could do a lot more in our healthcare system to prevent lifestyle-related disease, which ultimately led to the birth of Fruit Street as a summer project at the Harvard Innovation Lab many years ago. So,
yeah. And what does Fruit Street do?
Yeah, so we deliver the CDC's National Diabetes Prevention Program through telehealth and live group video conferencing on Zoom with registered dietitians. The program is designed to prevent the 1 in 3 Americans with prediabetes from progressing to develop type 2 diabetes. Prediabetes just means that you have elevated blood glucose and you have a high risk of developing type 2 diabetes. And the problem is that 1 in 3 Americans are pre-diabetic, but 8 out of 10 people with prediabetes don't know that they have it. So we first have to raise awareness of prediabetes and then enroll people into this program, which is based on a Medicare-funded clinical trial they did about 20 years ago, where they had 3,000 patients with prediabetes, and they compared metformin, the drug, to a placebo, to a lifestyle modification program that consisted of 22 classes with a lifestyle coach covering topics like diet, exercise, sleep, and stress management. And what they found was that the lifestyle program was more effective than metformin in preventing type 2 diabetes. The lifestyle group had a 58% risk reduction, and in patients over 60, they reduced their risk by 71%. So that was published in the New England Journal of Medicine and led to Medicare and Medicaid paying for the program, as well as employers and health plans. And then the CDC developed a national public health program where there's now 1,600 organizations delivering this evidence-based program. Most of them are in person at churches and hospitals and YMCAs. Yeah. We do it online through telehealth and live video chat with dietitians. The patients also get a scale and a Fitbit, and they can take pictures of their food in our mobile app. So it's basically a telehealth approach to a proven intervention.
Yeah, no, that's awesome. I'm going to pull this back a little bit because some of those statistics you threw out were pretty shocking. So you said 1 in 3 Americans are pre-diabetic or at risk, right?
Right.
What percentage of those people end up developing type 2 diabetes? Is it the vast majority? Because like you said, 8 out of 10 don't know that they're even on the risk factor, or like, I'm assuming this is a pretty significant problem.
Yeah, well, by some estimates, it could be up to 70% of people with prediabetes could develop type 2 diabetes at some point
Oh,
in their
holy smokes.
lifetime. And I mean, these trends are getting worse, right? I mean, I saw the other day an article that said the US obesity rate is now at 44%. We could be at 1 in 2 Americans being, obese very, very soon. So it is a big problem. I mean, you don't really know when you're going to progress from prediabetes to type 2 necessarily, which is why it's important to take it seriously. You can check if you're pre-diabetic by going on fruitstreet.com and taking the CDC's 1-minute risk quiz, where it will ask you some questions. But in order to truly find out if you're pre-diabetic, you would do a hemoglobin A1C test or a
Okay.
fasting glucose test. If you had an A1C between 5.7 and 6.4, you're considered pre-diabetic, as an example. But the best way to know is by taking that blood test.
Yeah, holy smokes. So obviously, once you cross into the world of having type 2 diabetes, then you're at risk for all kinds of other health issues, right? Wounds that don't heal and amputation, all those things that you said. So in the past, and I guess even now, it seems like the majority of this has been managed like in person at churches, at clinics. Like, how effective has that been? And then comparing that to maybe the virtual format, have y'all noticed any difference in success rates? Is there some kind of improved access? How's that been working?
Yeah, I mean, there have been some studies done comparing in-person programs to live classes, showing that they're equally effective. So I think that's been, established. I think the big approach with, or the big benefit of telemedicine is that you make it accessible nationally, regardless of where someone lives. There's many parts of the US where there is not an in-person
Yeah.
CDC recognized diabetes prevention program. And the idea that someone's going to drive 30 minutes, 60 minutes, 2 hours to get to the local CDC recognized diabetes prevention program is not realistic. Even if you live in a city, going to the hospital, paying for parking, it's just, why would you want to do that when you could just talk to a dietitian and a group of other people from the Fruit Street mobile app or from your computer? It just makes it more convenient, and the more convenient you make a lifestyle intervention, the more likely it is that someone is going to participate. Like if I do marketing to you and I say, hey, you can, click here and sign up now and do it from your home whenever you want, versus you have to come to the hospital at 1 p.m. on Wednesdays and drive and pay for parking.
Yeah.
That's
It's a
going to
bigger
change
ask.
how many people sign up. So yeah, I think that's the biggest difference. And then obviously you get some added benefit from the fact that you can have patients step on the wireless scale every day, so we're monitoring their weight. They're taking pictures of their food in the app, and so we're seeing exactly what they're eating, giving them feedback. You have the Fitbit, so it just keeps them a bit more engaged.
Is all that
well.
data kind of coming through the Fruit Street app? Like, is the information from their Fitbit bouncing over and they're able to review it and all of that?
Yeah, it's integrated through APIs, and the dietitian can also log in and see a list of their participants and click on a participant to see how many steps did they take that day, what was their weight, what did they eat that day, how many physical activity minutes did they log that week, and it's all uploading in real time. So in between these weekly live sessions, the dietitian can give feedback as well to the participant on their diet and things like that.
Awesome. Cool deal. Well,
yeah.
So it's been managed in person for a long time. We just talked about that. Now we're moving to virtual. So shifting the program into a virtual format seems like it may have come with some challenges. Were there any obstacles that you faced kind of getting the program deployed virtually? Like, how did y'all overcome it? Or has it been, have patients really, really kind of just moved into wanting to do it at their convenience online, all of that?
Yeah, I think there's different categories of challenges. One of them is reimbursement. So right now, Medicare only pays for the in-person version of the National Diabetes Prevention Program. They are temporarily paying for the virtual model for providers that were previously an in-person program.
Exactly.
So Fruit Street's still not included, unfortunately. But that's just because of the public health emergency. So right now, Medicare really doesn't pay for virtual across the board. there is a piece of legislation called the Prevent Diabetes Act that, if that was passed, would have Medicare pay for virtual diabetes prevention programs, which is really necessary to make it accessible to people.
Yeah.
I mean, the idea that you would force, a 71-year-old, person in Chicago in the snow to drive to a, diabetes prevention program instead of letting them safely do it from their home it doesn't make any sense, right?
Yeah.
So you have the reimbursement piece, but we've navigated that by selling to self-insured employers and health plans who can pay for kind of whatever they want in the commercial space. And also Medicaid pays for the program in some states. So we're pursuing Medicaid as well. And then there's just operational challenges. We're doing this at a pretty large scale. We've enrolled
Yeah.
more than 45,000 people. So the
Holy
scheduling is
smokes.
actually challenging. So we built this software system where like the participants could sign up and say, do they want a weekend or a weekday class? Do they want morning, afternoon, or evening sessions? And then automatically matches them to a dietitian and schedules the classes for the entire year. But if you do the math on, 45,000
Yeah.
people multiplied by 26 sessions, you're talking about, I believe that would be millions of calendar appointments he would have had to manually create if we didn't build the scheduling automation. So that was an interesting challenge we had to overcome.
Yeah. And I'm assuming like when someone logs in or signs up, does it like, do y'all work kind of cohort based? Like, okay, we've got 10 people and they're gonna, all go through the sequential 20 something visits, or how are y'all managing that piece of it?
Yeah, they are cohorts. So they go through the 12-month program with the same dietitian and the same group of 30 people. So if they select Sunday classes at 2 p.m. starting on September 3rd, they would meet on Sundays at that time 26 times in a year. It's weekly in the beginning for the first 12 weeks, then bi-weekly. And then the idea is to get them to 5% weight loss by month 6 and then have monthly classes.
Okay.
So it is cohort based. If they need to switch times, they can switch to a different class. But the idea is that you build this kind of support group and you go through the program together over the course of a
Yeah.
year.
Do the
Yeah.
participants get to interact with each other? Like, is there a forum or something like that? Or are they just all they're seeing each other at the classes or at the sessions?
Yeah, well, the sessions are very interactive. The
Okay.
dietitians are supposed to be doing a very minimal amount of talking. I mean, they introduce the topic for the week. So one week it might be diet, another week exercise. So the participants are doing a lot of talking on the group calls, but there's also a group chat in the Fruit Street app and web portal where they are talking to each other throughout the week as well. And the dietitian's kind of facilitating that text chat throughout the week. So there is both synchronous and asynchronous, communication between the participants as well.
Yeah, that's awesome. Well, I guess you said 45,000 people. Like, what is the I guess the engagement rate has been? It sounds like it's been really high. What about completion rates? Have y'all gotten some cohorts through? Like, how does the virtual management compare to traditional management as far as the like the outcomes, like successful completion rates of the program and the 5% weight loss and all that?
Yeah, well, the CDC runs something called the Diabetes Prevention Recognition Program that includes both in-person and digital programs. And, in-person and digital programs have both been proven to be able to achieve the same outcomes.
Okay.
And so the CDC, from a scientific perspective, does recognize both delivery formats as being valid. What Fruit Street does is a little bit different from our competitors is we have live classes. So we're called a distance learning program versus some of our competitors like Omada Health or Lark or Noom. They're classified as an online program, which means they have more of these like recorded
Yeah, like
pieces of
on-demand
content.
sessions or something.
Yeah, which it could be better for people that have a busy schedule. But on the other hand, Fruit Street might be better for some people. It depends on their preferences. Um, we've seen things like 1 in 3 people that attend the first class lose 5% of their weight. For example, naturally you do have a drop off in lifestyle change programs, even if it was the best in the world, because
Yeah,
it's just the nature of
it's
these
hard.
programs. So that's why we have a milestone based payment model, which is that to say that we get paid as people progress through the program. We get a payment when they sign up, when they attend classes with the dietitian, and when they lose weight, and that makes the payers more comfortable with paying for a lifestyle intervention because they know that they're only paying for people that are actually participating in the program as well.
Yeah, no, that's awesome. How about cost savings and the like? I'm assuming maybe obviously for the participants, they're not having to pay for gas, pay for parking, all of that. What about on the payer side of things? Like, is there some sort of cost savings to be made there from the prevention program being done virtually, or is it all those long tail benefits, like these people potentially aren't going to get type 2 diabetes, and all of the associated healthcare costs is going to come because of that?
Yeah, well, if someone progresses to type 2 diabetes, they would have about $9,600 of increased healthcare costs per year. And
Holy
so,
smokes. Okay.
if you only have to pay $400 for an intervention that reduces their risk by 58%, you save a lot of money. There was one study done with Medicare where for about a $500 investment, Medicare could save $2,650 within a 15-month period. So you can
Holy
get
smokes.
the return on investment pretty quickly. But it doesn't happen. I mean, that part of it actually happens pretty quick. That's pretty quick for return on investment.
Yeah.
But for other people, it might take 5 or 10 years to see that cost savings because it's something that develops over time. Someone could be in the pre-diabetic state for 5 years before they progress to type 2 diabetes. But imagine if somebody has to get an amputation or they go on dialysis or they have a stroke, it becomes quite expensive.
Yeah. Are you finding that the conversations you're having with potential client organizations are going pretty smoothly because of that? I mean, it seems like pretty stark numbers and it's a pretty easy value proposition. Are you getting much pushback? Is there some resistance, or is it like, what are those conversations looking like?
Yeah, I mean, it depends on the employer. We've had very large customers like Walgreens and Delta Airlines as customers, and they have such big populations that they're almost more progressive, right? Because they have such a big incentive financially to prevent diabetes. We also have worked with health plans like Care First, Blue Cross Blue Shield before. I think that during the pandemic, actually, the employers and payers were so focused on COVID that they it's like diabetes was not the main priority because they were in like a sensitive emergency. But I think now what's happened is that the pandemic's died down, and people have realized that one of the main reasons we had such a high mortality rate in the US from COVID was because of obesity and diabetes. And people also people gained a lot of weight during the pandemic, and now we have more remote workforces. So we need solutions like telehealth to be able to manage them. So I've seen more of a shift back into a focus on wellness and prevention now that COVID has died down a bit.
Yeah, so. No, that's awesome. Anything else about this type of program that you would want listeners to know? Like, I guess main points, takeaways, things like that.
Well, we've added some new features recently. We have an integration with LabCorp now where someone can sign up and get an A1C test when they enroll. So we're starting to recommend that we track A1C outcomes to the payers. There's another partner we've added called Modify Health, which has medically tailored meals as well that are designed to improve health outcomes. That's actually reimbursed through the California Medicaid program as well. But really, it's just the biggest challenge of a product like this is sales and marketing. It makes perfect sense from a product standpoint. It's like, well, why wouldn't you want to prevent diabetes and reduce healthcare costs? But you have to get the payers, on board with it. And so there's a lot of effort being put into that by the government. We were invited to the White House Nutrition Conference they had last year, which they had for the first time in 50 years. And it was actually refreshing to see a lot of senators and government officials promoting lifestyle-related interventions and really viewing it as a government problem, because at the end of the day,
it kind of is.
Medicare and Medicaid are paying for it. I got a cool photo with Senator Cory Booker at the conference. So he was very passionate about pre-diabetes, but I think the government's taking notice of the importance of addressing diet-related disease. It's a huge problem in the U.S. right now.
Are y'all doing a lot with your own data? I talk a lot about the value in some of these tech-driven enterprises, specifically in the healthcare space, is just the data that we've been collecting for years. Now we actually have a way to use it and to show ROI and to show the value there. Like, are y'all in the middle of, not call it like peer-reviewed research, but are y'all analyzing y'all's data, trying to figure that out, and then presenting that to potential customers and payers? Or what are y'all doing with all that?
We have had payers like Care First look at their claims data and show improvements in people that participate in our program. But I think one of the challenges of the digital health industry is that sometimes we have to keep reproving the same thing over and over and over.
Uh-huh.
Like I was invited by the CDC to participate in their lifestyle. I think it's called the Lifestyle Change Intervention Research Network, Lucerne, and we were just talking about it in the meeting about how we already had like a huge clinical trial done, which granted was an in-person program, but it's the same intervention, right? And so I think like it's been well established through hundreds of papers now that if we can help people live a healthier lifestyle and prevent diabetes, then it's going to save healthcare costs. But it's for some reason a bit different for payers to grasp
Yeah.
compared to like a pharmaceutical drug or a vaccine, where it's just, it's easier to maintain the fidelity of the intervention when it's a vaccine or a pharmaceutical compared to a lifestyle program. So implementing these programs is a bit harder, but yeah, we have done some analysis on our product specifically, but I think it's also important to point out the mountains of data behind lifestyle interventions really already
Exactly.
there.
Yeah. Well, how much
So
of that too is like you said, like it's easier to be like, I have this pill, and if you give your people this pill, they're gonna be fine. Versus like, we got to change the way they're exercising or eating and all of that. It seems it's a taller lift, right?
yeah, for sure. And I think that's why the CDC has this diabetes prevention recognition program where we have to report our outcomes data every 6 months, and we have to meet certain standards. So I think they're trying to have that program to say to payers like, hey, these are high quality programs that
They're
adhere
working.
to CDC scientific standards as well.
Yeah. Awesome. Cool deal. Well, Lawrence, thanks so much for taking the time. If people want to learn more about you, about Fruit Street, where can they do all that? Connect with you and learn more.
Yeah. Well, you can just go to fruitstreet.com, and you can find me on LinkedIn as well, Lawrence Gerard, and happy to connect with you there. But thanks for having us on the show, and we appreciate the work you're doing as well.
Yeah. Thank you. We'll link to all that in the show notes. So go check them out. Have a good one.
Thanks.
Well, I hope you enjoyed that conversation with Lawrence Gerard talking about delivering the CDC diabetes prevention program via telehealth. I think one of the things, first of all, correction, I misspoke at the intro. It's actually 1 in 3 Americans, so 30% of Americans are pre-diabetic, and up to 70% of that 30%. So of the 1 in 3 Americans, 70% of them are going to go on potentially to develop type 2 diabetes, which is just a staggering statistic. It's just staggering. So anyways, wanted to clarify that. One of the things that I was thinking after listening through the conversation again was just the value that clinicians provide. I've always said this. The value that clinicians provide is not so much our technical skills. I come from the orthopedic and the musculoskeletal world, so physical rehabilitation and the like. So when you bring up this idea of what's the value that you bring to the table, I've been in multiple continuing education conferences and seminars where people talk a lot about the technical skills, the exercises we can give somebody, the manual therapy, the myofascial release, whatever it is, the manipulation, the mobilization. And the reality is that treatment is valuable. It's just not the most valuable thing that we do. In fact, even the literature bears that out. That's a lot of those passive treatments, these technical skills where the patient is a passive recipient of the services you provide or the treatment the technique that you're delivering, are effective in the short term. They might reduce pain in the very, in the very immediate time frame, but long term, they are not effective. So what that means is that, yes, the technical skills are important. We want to use those at the beginning, but the long-term value comes from self-management, from basically empowering or enabling the patient by providing and educating, giving them the skills and the tools they need to manage their own symptoms, their own diagnoses, their own whatever, in the long term. And that involves things like lifestyle modification, habit forming, all of those good things that Lawrence was talking about. Like, it's much easier, and we as a culture, we want that magic pill, right? It's easier to sell somebody, Here is the pill that you take, and you'll be healthy, you'll be fit, you'll be wonderful, you'll never have pain again, and you won't have diabetes, versus, listen, this is potentially a big health risk, and here's what we've got to do. We've got to change the way you're eating, or we got to change your activity level, or the way you structure your daily routine that we decrease these risk factors. However, in the long run, those hard things are what causes and what has the better chance of improving and preventing those negative outcomes down the line. So it's one of those, it's a catch-22, right? We live in a world that really wants the quick, easy fix-it, but the quick, easy fix-it doesn't necessarily provide the long-term benefit. So when it comes to delivering these types of services, there is a big piece of that treatment or of that service that requires education on the part of the clinician delivering that program, for example, to this patient or this customer or client that is at risk for this chronic condition. Some knowledge translation needs to take place, some education, some training, and really that only is super effective or really effective when there is a relationship there, an established relationship of trust. So even though it's being delivered via telehealth, I wrote this a couple years ago in, I think the white paper that's on the website, rehabilitation.com, is something like Telehealth and the Future of Healthcare. And the main point that I wrote, or that I wanted to get across in that white paper, was that just because you're not in the same room as the patient or the client does not mean you are unable to effectively form trust-based relationships that you can leverage on behalf of that client or patient to help them achieve whatever desired outcome they're looking for. And that is a big piece in all of these programs, whether it be in person, whether it be via telehealth like Fruit Street is doing. We need to fundamentally understand that what we are doing is not giving a magic pill to a patient. We are involved in a real behavioral change and lifestyle change, and that takes time, it takes energy, it takes effort, it takes coaching, support, and mentorship. It's not just one of those one and done type things. And the organizations that do it well, that have good outcomes, if you survey their patients, I'm totally taking a stab at the dark here, but I would assume if you survey those patients, or if you were maybe to give their patients something like a care measure or a care survey, which is a validated assessment tool, after their interactions or after their course of care with that organization, they would rate very high on that care and empathetic relationship scale. Because in order to get or to successfully get a patient or a client to buy into some of those lifestyle changes, sure, they might be self-motivated to do it if they've had a health scare, or maybe they've seen family members go through it and they don't want to end up in those same shoes. A lot of times, though, because of the way humans are built, and it's easy to fall back into those old habits, we really do need a coach in the corner, somebody that's going to root for us, that's going to provide us the information, somebody that we can trust to take on those sometimes very intimidating lifestyle changes. If I was to tell you that you need to change your entire diet right now, that sounds like a big ask. But if we do things right, if we do incremental steps, the whole idea of tiny habits over and over again, that only, in my opinion, really only happens once the relationship is established, and that relationship doesn't necessarily need to be completed only in person, right? It can be done via telehealth. So I think it's great what they're doing. I also think the idea of getting payers and stakeholders to begin paying for these types of services before the patient becomes diabetic or obtains that or gets classified as having this chronic condition is going to be one of those things that we see over the next several years that becomes more popular. Because again, the cost-benefit ratio and analysis very much plays in the favor of preventing some of these diseases. So hopefully over time we'll begin to see that being incorporated as just a standard benefit in some of these plans. So anyways, that's all I've got for now. If you like the show, normally I ask for a rating or a review, but I'm on a new kick. Share it with somebody that you might think would find it interesting. That's how you can help the show. And hopefully that will lead to more ratings and reviews and subscribers. If you run an innovative healthcare organization and you are looking for assistance in positioning your service offering or in market penetration, head on over to rehabilipracticesolutions.com. I'd love to have a conversation with you and see if there's a way that I can help. In the interim, between now and the next episode, be safe, be healthy. I will talk to you then.
Thanks for listening to the Better Outcome Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabilipracticesolutions.com. We'll catch you on the next episode.
Trying to grab all the groceries in one trip? Oof, not how you would have done that. You know sometimes less is more. Like when you drive less and save with the USAA annual mileage discount. USAA. Get a quote today.